Hi there, thanks Monty. I'm Harry, one of the anaesthetic trainees in Swansea. Today I'll be talking about our work in Swansea using Ketofol, so a combination of propofol and ketamine for changes of dressings in adult burns patients, mainly on the intensive care unit. So just as a background, Swansea is a tertiary burn centre. We take high percentage burns for intensive care management from across Wales and the southwest of England. And in general, in addition to sort of ongoing intensive care management and theatre trips, these patients require regular dressing changes for minimising wound infection and for assessment of the wound itself. Obviously, while they remain intubated and ventilated on ITU, it's a relatively straightforward procedure. We can just sort of increase the sedation that they're on at the time. But after extubation, it's a particularly painful and distressing procedure, and it can result in further general anaesthesia just to change these patients' dressings. So the Ketofol, in a sense, it's been around for a while. I know it's been discussed in the literature since around 2003, and there's a bit of evidence for it being used in procedural sedation and analgesia in the emergency department, but using it in the adult burns population is a fairly novel idea. We haven't seen any evidence of it being used elsewhere. We've been using it in Swansea since around the end of last year, and we're getting some good protocols in place for its use with regards to monitoring needed and pre-medication given. So this poster, we've got just a case series really of 3 patients of quite a few we've done in Swansea now, ranging from percentage burn areas from 9% up to 61.5%. And all these patients, Ketofol was used successfully, and it helped to avoid general anaesthesia in these patients. So for the first case there, you can see I've got a chart. This guy had at least 6 dressing changes, and there was incremental doses given of Ketofol, and this dose that he needed sort of reduced every time. As you can understand, as the burn heals, it's sort of a less painful procedure every time. We found that it's relatively safe. It can be given in incremental boluses, so you can sort of titrate the amount of Ketofol you need. And it's got lots of benefits that included analgesia, airway preservation. The patients sort of continue to breathe for themselves. They have hemodynamic stability, and they have rapid recovery after the procedure as well, because the total dose of both ketamine and propofol is sort of reduced over the time that they have the dressing change. And also can be given for long periods of time. So 90 minutes was sort of the longest dressing change we had for one of our patients. And this was used on ITU. We've also used it for non-ITU patients, if you like. So there's one patient on there, the third case. The chap only had 9% burns, and he was able to be used for the same sort of things. So usually Ketofols, you didn't have to have sort of the really high percentage ITU type patients. So not only did they get to avoid general anaesthetics, for the patients that were already in ITU, we didn't have to take them to theatre. So you can utilise theatre for sort of newer admissions, and the patients could stay in their ITU room and not have to go to theatre. So sort of cost savings there as well. So although there's not much evidence, we found it extremely useful in our centre. We've used it on numerous patients, and we've used it for about 9 or 10 months now, and it's proving very helpful. So thank you.
Brilliant, Harry. Thank you very much. Thank you very much indeed. Very clear. Claire's up next. Hi, Claire. I think you might be muted. I think you might be muted at the moment, Claire.
Sorry. Hi. My name is Claire Healy. I'm an anaesthetics SHO working in Cork University Hospital, and I'm going to present the findings of an audit that I did with Dr. Kim O'Brien and others investigating the preoperative fasting times in the geriatric patients with neck of femur and lower limb fragility fractures in CUH. So I suppose just a bit of background, CUH is one of the only level 1 trauma centres in Ireland. And
Claire, if you could just pause for 1 second, I'm going to ask everyone to turn their cameras off, because your signal seems to be a little bit weak.
Oh,
so
the rest of us are all going
to turn our videos off to give you the best possible chance. Okay. So if you want to start again, we can edit that bit out.
Yeah.
There we go.
Perfect. So my name is Claire Healy, and I'm presenting an audit, the findings of an audit that we did in Cork University Hospital, in which we investigated the preoperative fasting times in geriatric patients with neck of femur and lower limb fragility fractures. So Cork University Hospital is the only level 1 trauma centre in Ireland and performs a large majority of orthopaedic trauma for the Munster region and performs all of the orthopaedic surgery for traumatic fractures in Cork. So in recent years, there's been a change in how patients are fasting, the guidelines that are provided. So what used to be the kind of nil per os fast from midnight has kind of changed to a more contemporary perioperative care pathway with patients on enhanced recovery programs, which allow them to have oral carbohydrate drinks up to 2 hours preoperatively. In particular, orthogeriatric patients tend to be at very high risk of having adverse outcomes associated with prolonged fasts, especially those who have lower limb fractures, as due to the nature of their injury, they will have excessive bed and prolonged bed rest if they are have long waiting lists for their surgery implemented in Cork University Hospital by the orthogeriatric teams, whereby the patients were advised to have IV fluids commenced at midnight the night before surgery. They were meant to be allowed to eat until 2 a.m. and continue free fluids until 6 a.m. on the day of surgery. But it was very unclear as to whether these guidelines were known about and being adhered to. And so the main aim of this audit was to establish accurate preoperative fasting times for these patients. And we also wanted to identify the incidence of repeated fasting, and if patients were cancelled, what the reasons for cancellation was. So we included all orthogeriatric patients, that's those over the age of lower limb fragility fractures, and we excluded any patients that required intensive care unit care prior to their surgery. And we obtained the data from review of the patient's notes, the anaesthetic records, and the nursing notes. We found that the median fasting time for patients was 17 hours on presentation to theatre, and if we added the time to their first meal post-operatively, this increased to 27 hours. We found that nearly 2/3 of patients were cancelled at least once, nearly a third cancelled twice, 13% cancelled 3 times, and 6% were cancelled 4 times, which gave a total median perioperative diagram below. Overall, we found that many of these patients were being fasted inappropriately, and the main reason for it was poor communication between all the healthcare workers involved. So we're currently in the process of trying to implement change and subsequently improve this for the patients. So we have 3 recommendations that we're hoping to implement in Cork University Hospital and subsequently re-audit to see has it been effective. So one of the things is that in CUH, the orthopaedic theatre list is paperless and colour-coded for giving whether a patient is genuinely scheduled for theatre today, or if they've been cancelled for a medical reason, or if due to overrun. And this isn't accessible in the wards, and so the nursing staff on the wards don't know if the patients are actually being fasted for theatre or not. And so if that could be collaborated together, that they'd be able to see that, we feel it would help with patients having reduced fasting times. We're also hoping to implement carbohydrate energy drinks prior to surgery, similar to the colorectal patients, to help physiologically optimize these patients, and also just to try and implement behavioural changes, so with informal teaching sessions and posters around the hospital to kind of share our findings and recommendations on this. Thank you.
Thank you, Claire. And well done for battling through your slightly suboptimal internet signal, but well done. So next up, please.
Hello.
Hello.
Yes, I'm here. My name is Patel. I'm an intensive care registrar at the Royal Adelaide Hospital, and today I'm presenting for you Fit for Surgery, which is a study to explore the need for a prehabilitation programme for patients undergoing major surgery at Western Sussex Hospitals Trust. And a prehabilitation programme is a process of cardiorespiratory optimisation, medical and nutritional optimisation, and the involvement of psychological support. And there's early data that suggests that with prehabilitation, you can reduce morbidity and length of stay and significantly improve the quality of life. And with our elderly population with a high burden of cardiorespiratory illnesses in Worthing, we wanted to know whether there was a potential for prehabilitation to have a significant impact. And this is a graph by Macmillan Trust, which suggests that with prehabilitation, you're more likely to return to your baseline function than without it. So we underwent a retrospective 2-year review of the cardiopulmonary exercise tests, or CPET tests, at Worthing Hospital, and we collected data on demographics, medical indicators like hemoglobin and renal function, and we looked at several parameters of the CPET tests, which I've outlined under the methods there. And then we risk stratified the patients according to this. And our results showed that there was a lot of scope for medical and nutritional optimization. 2/3 of our patients were either overweight or underweight and would benefit from a dietitian review and input. 50% of our patients were anemic as per WHO standards, and there's a lot of studies out there suggesting higher complication rates with anemia. 40% of our patients had moderate to severe CKD, which would need to be under review. And interestingly, 2/3 of our patients had a raised VE/VCO2 at anaerobic threshold. And this value is indicative of ventilatory efficacy and suggests that there's a high percentage of our patients that have raised VQ mismatch and dead space, which could also be addressed. And the most interesting part of our data is in these 2 graphs at the bottom. And this is when we risk stratified the patients as per their peak VO2 and anaerobic threshold. And previous studies have suggested that there's an increased risk of complications with a peak VO2 of less than 15 or an anaerobic threshold of less than 10.9. And from our data, almost half of the patients were in this high risk group with a peak VO2 of less than 15. And we calculated that if we can improve their peak VO2 by 10%, we can reduce the number of patients in the high risk group by 30%. And if we improve the peak VO2 by 20%, we can actually improve the number of patients in this high risk group by 60%. And if we look at this from the point of view of the anaerobic threshold, if we can improve the anaerobic threshold by 20%, then we can halve the number of patients in the high risk group. So just by improving the peak VO2 and anaerobic threshold, we have the potential of significantly improving these risk outcomes. And there's studies that suggest that we can improve peak VO2 by up to 23% by means of a prescribed exercise regime. And in particular, Carly et al. Have a study that suggests that a hospital-based exercise program has much better compliance and outcomes for these patients. And at Worthing Hospital, we're a district general hospital, we do have the facilities in order to implement this. We have an exercise facility, physiotherapists, dietitians, and physicians for review and input. And we would just need to orchestrate this in order to really hit this golden opportunity from diagnosis and before surgery to try and improve these risks. So in conclusion, the introduction of a prehabilitation program at Worthing Hospital has the potential to result in a significant improvement in the predicted outcomes for patients following major surgery. And now is the time to try and translate these changes into real clinical differences in morbidity and length of stay.
Thank you very much. Next, please.
Morning, everyone. My name's Gary Rodgers. I'm an intensive care and anaesthetic registrar, and here representing the work of Aintree University Hospital in Liverpool, the incidence and importance of anaemia in patients undergoing liver resection surgery. So why did we undertake this work? Well, first of all, we had very little idea about our blood management of these patients. So we had no idea really what their pre-op anemia rates were, how often we were transfusing them, and what their associated outcomes were. And this is a particularly important patient group for blood management, as about 66% have major liver resection surgery as a result of metastases, mostly from colorectal cancer. So they're a very high-risk patient group for being anemic preoperatively. And there's very little, in fact, nothing that we could find that demonstrated any outcomes in the UK about anemia in this patient group. So the aim was to analyse the incidence of preoperative anemia in the major liver resection group and its association on outcomes at this single site. So how did we do that? So we looked at all our liver resection patients over a 2-year period. That amounted to 182 patients, and performed retrospective cross-sectional analysis of that patient group, looking at their demographics, their hemoglobin concentrations, their blood loss, their transfusion rates, and their associated outcomes. And what our findings were interesting, if not to anyone else, but at least to us. And we found that about 30% of this patient group, 55 out of the 182, had preoperative anemia, and males are much more highly represented in this group, 45 males, 10 females, and were more likely to be anemic. Our transfusion rate, the surgeons thought that we were transfusing around about 10%. And in fact, we had a significantly higher transfusion rate than expected, and we were transfusing about 15% of these patients. And perhaps unsurprisingly, if you were anemic, you were much more likely to require transfusion in the perioperative period, with the associated costs to the patient and the change in risk and long-term survival, and also the financial cost of transfusion in these patients. If you were anemic, you were much more highly represented in the major morbidity category. And preoperative anemia was significantly associated with serious complications, the most common of which were deep space infection and postoperative infection. Interestingly, in the smaller study, there's no difference in mortality at 30 days or 1 year, although there was a signal towards 30-day mortality. So what did we find? So we found out that we had a much higher incidence of anemia in our liver resection patients than we thought, that anemic patients were disproportionately represented for a need for transfusion and for serious complication, and that we needed a series of targeted interventions pre-theatre in order to maximise the outcomes in this patient group. And this has led to the institution of pre-op IV iron in this group of patients. Thanks very much.
Great, thank you. Well done. Next, please.
Good morning. My name is Robert Lee. I'm working as a senior house officer in Galway University Hospital in the Department of Anaesthesia. And I'm here to present the findings of an audit we performed on our practice of labelling epidural infusions for our post-operative patients. So in our hospital, we have a policy in line with recommendations from the NHS that certain key sites of an epidural infusion be labelled with a sticker which identifies it as an epidural infusion, with the aim of reducing the risk of errors at these 5 critical sites. These being the epidural pump itself, the infusion bags, the administration sets, the epidural catheters, and the drug cardiacs. And this is with the aim of reducing the risk of medication error, be it medication administration or co-prescribing, to ensure that patients who are receiving an epidural infusion post-operatively can experience the benefits of it with the greatest assurance of safety. So what we did was we reviewed the epidural infusions of the patients on our wards over a period of several weeks, and recorded whether or not a label was present at each of these key sites. The findings were rather disappointing. We found that a little over half of the pumps themselves were being labelled as such, that 18% of the infusion bags were labelled as such, 47% of the infusion sets were labelled, 18% of the catheters, and just 7% of 15 drug cardiacs, as 2 were excluded from this audit, where the patients were admitted to the intensive care unit, where electronic prescribing supersedes the written cardiacs, where you can affix a sticker to. So the results are quite disappointing, really. And so the significance of this, I suppose, is that with these patients being discharged from theatre with an epidural infusion, the prescribing physician who's placed the epidural may overlook the fact that these patients go back to a site where staff are less familiar with epidural infusions than perhaps they would be. And so the risk of errors is perhaps higher than perceived. So following on from this audit, we believe that simple measures such as prompting, posters where epidural infusions are being prepared will be sufficient to address this issue, hopefully. We plan to re-audit this in the coming weeks now, especially as planned surgery resumes in our centre following the relative shutdown with the COVID-19 crisis. And following the results of that re-audit now, we'll see if any further measures need to be taken. Thank you.
Thank you, Robert. Well done. Next, please, is Geoffrey, I think.
Hi, my name is Jeff. I'm an anaesthetic trainee from Western Health, which is a health network in the west of Melbourne. So I'm here presenting the work of the compliance audit with the 3-point smoking cessation strategy coined Ask, Advise and Refer. So We know that tobacco is a leading modifiable risk factor, and it's becoming and is frequently dealt with in the preoperative assessment. The reasons being that it has long-term health benefits for not only the patient, but also the ongoing care and reducing risk of complications. It's also becoming well recognized that it possesses a teachable moment at preoperative assessment time going in for elective surgery to encourage smoking cessation. The smoking cessation strategy, the AIR, is one that's used by multiple national professional bodies, including that by ANZCA, which is the body in Australia. So the aim was to assess the compliance with the smoking cessation strategy when used in the preoperative preoperative assessment setting. So we recruited 150 patients aged 18 or over, presenting consecutively to the pre-admission clinic for elective surgery, either via face-to-face or telehealth appointment. That suddenly changed through the audit due to COVID-19 restrictions, and they had their EMR records pertaining to the appointment reviewed. So from a results perspective, we had, as one would expect, a wide variety of specialities, but predominantly reflecting major surgery. Results demonstrated smoking prevalence to be roughly equal between both groups, men and females, 21%, with the mean age being around 64 years of age. Most likely group that were to smoke were that age 36 to 45, and not surprisingly, head and neck had the highest prevalence of smoking within it. So with respect to key findings, 99%, almost 149 out of 150 patients were asked about their smoking cessation in PAC. And of those, that's 30 were found to be current smokers, and 15 of those were advised to quit smoking. However, none of those patients were prescribed NRT, nicotine replacement therapy, or referred to Quitline, which is the local resource for smoking cessation therapy. So while we demonstrated a high compliance with asking about smoking cessation, which is the first step in obtaining or giving advice on smoking, it was disappointing to see the rest. But 50% of current smokers being asked to quit is in line with the British Thoracic Society guidelines. We suspect we were able to ask most patients about their smoking cessation due to the way that the telehealth structure was done, in which there's a pre-formatted interview script that's given to the PAC nurses, and the documentation is clearly done on EMR. The factors why they weren't given NRT or referred to Quitline are multifactorial, and it may be the fact that we use a bridge noting. Often when we use electronic medical records, we've only started using EMR in the last 12 to 18 months. And the fact that things have been suddenly changed and the lack of face-to-face has prevented patients being given NRT directly. So going forward, what we've done is we've developed a structured patient interview to include all elements of the AR strategy on the EMR form. And we developed a program that allows NRT to be delivered to patients by the postal service when the consultation is done by telehealth. Cool. Thank you.
Thank you, well done. So Krupa.
Morning, everyone. I'm Krupa. I've been working as a registrar in London Northwest University Trust Hospital for the last couple of years. I've been in anesthetics for quite a long time, and I'm trying to get into training now. But just trying to present one of the cases I've had when on call. It was in the middle of the night. Lady had a top up for epidural anesthetics. I'm just going to go through that and we'll follow it. Here I'm presenting a unilateral Horner syndrome following an epidural top up for a trial of labor. The case report I'm presenting is about a lady who was 20 years old, quite young. She had an epidural sited in the morning for epidural anesthetics, and she came for a trial. Topped her up with a test dose. There was no incidence to show that it was in an intrathecal catheter of the migration. There was no motor blockade. After the test dose, gave her a top up of ropivacaine. Altogether, the total dose was 15 mils of ropivacaine with 75 milligrams of fentanyl in it. We had a good block. The sensory blockade was about T4 level, and she had a good motor block as well within about 8 minutes of time. quite happy with the block. She was hemodynamically very stable. We did the trial. It was a successful outcome. The episiotomy was later sutured, and then she was transferred out to the recovery. That's when we started noting that her right eye was a bit droopy, and there was nothing else. She was very comfortable. She didn't complain of anything, but we could see that the right eye was droopy. It was looking a bit hyperemic. So we did think it could, I did think it could be Horner syndrome and nothing else, but did monitor her for all the hemodynamic monitoring, because we just want to know that the block shouldn't ascend further. The block was still at T4 level at that point in time. She was relatively comfortable. There was nothing else, and monitored her, and it almost disappeared by about a couple of hours. She was in the recovery a bit longer than the rest of them, and we just transferred her out later, and she got discharged. This is just to highlight that Horner syndrome can be one of the rare complications of epidural anesthetics. We generally don't see them, though it happens, just to identify this one and make sure that it doesn't progress any further to a total blockade or any further neurological impairment. So just to keep it on the brink of your eyelid that, yes, this is a possible complication, could happen among many of the others, but yeah, it's a rare one. Just highlighting that.
Thank you, Krupa. Very, very useful. Thank you. And we're back to Claire. So if we can all turn our videos off again to give Claire the best chance of coming to us from Cork, I think. Claire?
Yes. There was a storm yesterday. So I'm just going to present the findings of the study that we did about practical skills during the pandemic, where we tried to teach hands-on skills virtually. So in Ireland, during the COVID-19 pandemic, medical schools expedited all of their final year exams, and the interns who were coming in this year graduated early and began working early. So in the South-Southwest Hospital Group that's affiliated with University College Cork, they started working in May, as opposed to mid-July, which is the norm. Under normal circumstances, these incoming interns have multiple teaching sessions that are practical and theory-based, but University College Cork decided to run all of their induction online this year. Clinical skills such as cannulation, which is what we're discussing here, is normally taught during medical school on mannequins, and some but not all students have the opportunity to cannulate patients on placements during their medical school career. So myself and Dr. Aisling O'Maher, two anesthesiology SHOs, presented a 15-minute PowerPoint presentation that we pre-recorded for this induction. This kind of included just the general setup for cannulation, tips and tricks that we had felt we picked up during our years as practice, and things that we found as anaesthetists are helpful in kind of optimizing the success of cannulating a patient. We also provided them with a single-page summary PM while they were working on the wards. We asked the incoming interns to complete 3 questionnaires via SurveyMonkey. One was done prior to the presentation, one was immediately after, and finally 2 weeks after the July changeover. So at that point, they'd been working for about 8 weeks, 2 of which they'd been working independently. For their first 6 weeks from May to July prior to changeover, they were shadowing the current interns. So in the questionnaires, we asked them to grade their confidence with cannulation and for their opinion on the method of teaching. So 174 interns attended the induction, and the 3 questionnaires were distributed and completed. We had 77 people responded to the first questionnaire, so that was a 44% response rate. And 84% of them said that they had previously cannulated a patient. For the second questionnaire, the one that was provided immediately afterwards, there was 47.1% response rate, and of those, less than 50% had any degree of confidence with their cannulation. So that's the top bar chart in figure 1, with the yellow and green bars. So there's just less than 50% of them were confident with their cannulation skills. Questionnaire 3, which was provided 8 weeks after, we had quite a poor response rate of 14.9%, but of those who did respond, 92% reported some degree of confidence in their capabilities. So in contrast, that's the bottom bar graph with the yellow, green and blue. Of all of the respondents, 92% of them felt that it was beneficial, but they all felt that it would have been more beneficial as an in-person presentation. And as expected, we had a significantly poor follow-up after the initial presentations. So I suppose virtual teaching sessions do have their place, but they can't really replace in-person sessions, especially for practical skills. In recent years, within all medical specialties and in medical education, there has been an increased emphasis on simulation and for practical skills and preparation. And it's likely that, given with the COVID-19 pandemic, that this is going to drive alternative teaching methods for med students and practicing doctors alike. And this will just show the importance of of ensuring safe and effective practices and finding a suitable alternative for this. Thank you.
Well done, Claire. Thank you. Now we got Robert again.
So this is another audit that I've performed with my colleagues at Galway University Hospital. This time looking at the monitoring and assessment of patients undergoing electroconvulsive therapy under general anaesthesia. So the importance of this audit we found was that the provision of ECT is generally done at an off-site location, away from the main theatre, away from staff who will be familiar with the provision of general anaesthesia, away from familiar equipment, so very much in an area where you, out of one's comfort zone. So we wanted to assess how the monitoring was being conducted for electroconvulsive therapy and how the patients are being assessed, given that there are very clear recommendations from the AAGPI, from the Royal College of Anaesthetists, and from the ECT accreditation service itself. So for this audit, we reviewed the anaesthetic records and the recovery room records for patients for sessions spanning the course of about a month, collecting data such as the monitoring parameters, the patient's ASA grade, the date of the assessment as compared to the date of the procedure itself. And most notably what we found was that so about 38% of the patients who are deemed ASA 3 or greater were being pre-assessed in advance of the procedure date. The monitoring standards during and after the procedure was more or less 100%, bar the use of a peripheral nerve stimulator, which notably was at 0%. And other parameters in line with these recommendations were all fully within the recommendations of the guidelines. So the two main issues that we found from this audit was the lack of a peripheral nerve stimulator to monitor neuromuscular blockade where every patient was receiving succinylcholine, and also the pre-assessment of potentially higher risk patients for anaesthesia. As regards the peripheral nerve stimulator, there happens to not be one available in the ECT suite itself, and so that's being addressed by the anaesthesiology department in Galway University Hospital with the purchase of more nerve stimulators. And as regards pre-assessment of patients, we're trying to encourage that the Department of Psychiatry make use of the referral pathway to a pre-assessment clinic, which we provide, and which is well utilised by the surgical service. And so with that, we may be able to identify patients who who are at risk of complications, which is of course of the utmost importance when you're providing anaesthesia at an off-site location with less support and unfamiliar surroundings. And after both of these interventions have been performed, we plan to re-audit this and see if any further measures need to be taken or if we need to keep persisting what we're doing. But this is what we found. Thank you very much.
Thank you.